Kia ora and welcome to Goodfellow podcasts. This episode is kindly supported by the Royal New Zealand College of General Practitioners, the Auckland faculty. Today I welcome back to the podcast Dr. Matthew Phillips to discuss functional neurological disorders. Matt is a full-time clinical and research neurologist at Waikato Hospital in Hamilton. His foremost passion is to explore the potential feasibility, safety and efficacy of metabolic strategies, particularly fasting and ketogenic diets, in creating metabolic states that may improve not only the symptoms, but also the function and quality of life for people with a variety of difficult disorders. In 2021, Matt and his team published the world's first randomized trial of a ketogenic diet in Alzheimer's disease. Kia ora, Matt, and welcome back to the podcast.
Hello, Louise. Thank you very much for having me.
So today we're providing an update on functional neurological disorders, or FND, which is a disorder that arises from an abnormal nervous system functioning where there is no identifiable organic disease. The diagnosis is based on typical features that are real and distressing for the patient, and mood disorders often coexist. With the correct treatment, the majority of patients have an excellent prognosis. So Matt, to begin with, can we have a definition of functional neurological disorder, please?
I think you pretty much covered it. In neurology, we see structural disorders and functional disorders both. Traditionally, we've seen a lot more structural disorders, and that's what we're trained in. Things that are associated with a lesion or some kind of structural or cellular abnormality if you look hard enough. So like stroke, multiple sclerosis, Alzheimer's, and so on. But functional disorders are probably a growing portion of what we see. I'd estimate a third, 30% of what I see now is functional neurological disorders, or FND. And I see these as brain processing problems. So typically the tests, the investigations are normal, or there's minimal pathological change there. And you have yet got a person in front of you who has a number of absolutely debilitating symptoms. These are sort of brain processing issues. I explain it as the neurons are simply not communicating or talking effectively. And this is resulting in sort of a skewed perception of reality. And they really can manifest with any symptom or sign. And often people have many different kinds of them, even sometimes running into the double digits.
What sets FND apart from other neurological conditions?
It is a processing disorder as opposed to a sort of structural disorder. And what sets it apart is when you talk to a person, you take a history and you do an examination, they often have multiple different symptoms, far too many to indicate the presence of one or even several structural lesions. In neurology, we like to try and localize the lesion. So we like to have people with a few symptoms and signs and tell us, oh, there's a lesion in the right cerebral hemisphere, or, oh, there's a lesion in the cervical spinal cord, or, oh, there's a lesion in the median nerve, or something like that. But with functional neurological disorders, these brain processing issues, you're unable to do that because it really is a problem with the distributed processing aspect of the entire brain. So you can get symptoms and signs that really don't localize well at all, or even at all. And so that is one thing on history when you talk to people is that there's just so many different symptoms and signs. It's hard to make sense of it if you're thinking from a structural point of view. And then the symptoms and signs of these processing disorders change quite dramatically through time. So you might get one symptom and then that same symptom might come in a slightly different form the next day, and it might last a lot longer or a lot shorter. And then you might get a couple of different symptoms that evolve over the next couple of weeks. And then one of those might go away, and then you get another couple of different symptoms that evolve over the next couple of months. So it's constantly changing and shifting like a chameleon, I guess. And it adds to the complexity. If you're trying to think along the lines of localizing lesions and structural levels, it makes it extremely difficult to use that approach, in which we were all trained as neurologists to use that approach, these disorders. And this is one of the reasons many of my colleagues, I think, find this extremely frustrating, this kind of disorder. So there's a couple things. When you do examinations, there are certain positive signs you look for. So you look for if someone's got a weakness as part of their FND, then you look for something, like give way weakness. And there's a couple of other patterns with names attached to them, the Hoover sign and so on, that you can look for. There are aspects if they have loss of awareness, so like these dissociative attacks, which a lot of people confuse with seizures, but they're completely different. The dissociative attacks clinically look very different to seizures usually, although superficially they look similar because they're both characterized by convulsions. So dissociative attacks will often have the eyes closed. The head might shake side to side in a no-no pattern. The person might be emotional afterwards instead of very confused. They sometimes present as sudden motionless unresponsiveness or even as outright syncope. So the person sinks to the ground and just lies there with their eyes closed. So none of these things are really typical of seizures. Seizures are quite different. Then there are other different kinds of functional gaits. There's a number of subtypes of functional gaits, the walking on ice gait, the swaying gait, the crouching gait, all these different gait types that really don't happen with structural disorders. There are different gaits for structural disorders. So there's all these examination signs you can look for. And then, of course, the last thing that sets these disorders apart from structural disorders is the tests. So you do the imaging, the MRI brain, the MRI spine, and it's usually plumb normal, or there's some minimal pathology that doesn't explain the symptoms at all, really. And you might do nerve conduction tests or EMG or blood tests to look for the cause, and it's all usually comes back pretty unremarkable. So that sort of sets them apart. They're really distinct if you look at things from a history, examination, and investigation level.
So I wonder if I can pick up on that. Are there particular common symptoms or presentations that clinicians should be aware of? And is there a typical sort of patient who presents with a FND?
It does affect younger women more, but both genders and all ages are prone to them. But younger women seem to get the brunt of them. I think it has to do with the fact that younger women have probably more malleable brains, more neuroplasticity than older people, and generally women a little more than men. In terms of what to look for, well, I would say as a GP, because the consult times are so darn short, if you spend 5 minutes talking to the patient and they're giving out symptoms and they're still going, and you're very confused, then chances are creeping up that it's probably one of these. If they have a list of symptoms, that's known as the list sign. That's actually an extremely reliable indicator that you're probably dealing with a functional neurological disorder or one of its cousins. There's other brain processing disorders in my perspective as well. So like, chronic fatigue syndrome, I think falls into this category, sort of a cousin of FND, and as does fibromyalgia and irritable bowel syndrome, a few others. So if they have a list, your alarm bells should go up and go, okay, this person has written down all these different symptoms, and here we are. If they have symptoms that are running into the double digits and you don't have a list sign, but you've got 10 or more symptoms or something, you're probably starting to look at one of these disorders. And just remember the patient is usually extremely frustrated and debilitated, and they may have seen other colleagues beforehand who maybe weren't able to help. I think a lot of these things are indicative of the fact that you are probably dealing with an FND rather than something else. But you still need to do a proper history and examination and do the workup properly in order to be really sure sometimes.
So if we have a patient and we're wanting to elicit a history, are there tips or tricks that you have to get what you need in a short period of time?
Yeah, this is a hard one for a 15-minute slot. So the best trick is to just listen. Ask them the usual questions. How are you? Tell me about yourself, so on. But then just listen. And it takes time, unfortunately. They're going to list symptoms and signs, and you have to actually get through all of them. So this is old technique called draining the symptoms dry, which isn't so much in vogue anymore. But you really do have to just ask them. And if they stop at, symptom number 8 or 9, you say, please keep going. Is there anything else? And then I specifically ask about fatigue and sleep, because often people don't mention fatigue and sleep, although, fatigue dominates your wakefulness experience and insomnia dominates your sleep experience. So you have to ask about those two in particular. And one of them will pretty much always be there, usually both. So that's the best technique, is just you got to listen and get it all out. And that itself, actually, you've started the therapeutic relationship right there, because there's a good chance you might have been the first doctor to actually not get kind of frustrated yourself and actually just listen to all 15 symptoms. The top number of symptoms I've had is about 35, by the way. So 10, 15 symptoms isn't that much really for an FND. It's pretty stock standard.
And teasing out coexisting organic disorders such as migraine, MS, or epilepsy, how common is it to have a coexisting organic disorder?
I couldn't give you percentages because the thing is, we're learning so much about these disorders, the percentages are shifting. But they're common. It's common to get something like migraine headache associated with it, or carpal tunnel syndrome for some reason associated with, or a joint hypermobility syndrome such as Ehlers-Danlos associated with it for some reason, thyroid disorders, B12 disorders, sometimes demyelination, which, like a multiple sclerosis kind of thing, but there might just be demyelination on a scan, but, the patient doesn't clinically have MS. those are the kinds of things you look for, and it's actually pretty common. And so when I do see someone and I do a exhaustive workup, for example, I had a young woman last week on the ward with what I ultimately diagnosed as a functional dystonia, and nonetheless I did a full workup: MRI brain, MRI cervical spine, and nerve conduction studies, and a number of blood tests. And I wasn't looking so much for something else to explain the functional dystonia because I was confident that's what she had. But I was looking for any coexisting pathology: carpal tunnel syndrome, maybe some bit of demyelination, subclinical in the brain, or maybe a tiny radiculopathy that, like, due to a disc problem in the cervical spine. So, which could explain which is a part of these FNDs, because often the FNDs grow. I think a lot of the times there's an associated small structural lesion that wouldn't really normally cause that much problem, but the person's brain creates all this functional, we call it functional overlay, all these symptoms, varied symptoms on top of that. I see it as the brain trying to figure out what the heck's going on internally, and it creates a lot of the symptoms, because ultimately the brain it generates a lot of our reality, which is the key, I think, to understanding and treating FNDs. So we do an exhaustive workup to look for that. But I would say if you look hard enough, you're going to find a small structural disorder potentially 25 to 50% of the time, just anecdotally, or some other disorder.
Matt, you mentioned examining the patient and some special tests. I wonder if you can talk us through some of those a little bit more.
Oh, okay. So the examination, it really depends on what you've got for the FNDs. So some people present with weakness. Some people present with a movement problem. Some present with dissociative attacks, so loss of awareness. Some present with a lot of pain. So you really have to tailor your examination to it. And to be honest, the history is, I would say, 90% of the diagnosis. And the examination is rarely super helpful. I think the best thing about doing a good examination is that the patient knows that you're looking hard and you've taken them seriously, and you're really trying to tease out if there's any other structural issues going on. But there are features of the examination for the functional symptomatology example. Like I said, like for someone with weakness, it's collapsible or give way. And if you have someone with a dissociative attack, there are certain features. So I ask people to show me a video of a couple of different events. I call them events. I don't call them seizures. I don't call them dissociative attacks until I know exactly what they are. So that's helpful. In terms of if they have a tremor, like a functional tremor, there's something called the entrainment test you can do on the examination, which is basically a test of distractibility. Whenever you distract people from a functional symptom, it often gets better or goes away. So entrainment testing for a tremor is very useful. So there are all these sort of little, I won't call them tricks, but techniques that you can use to tease out, functional symptomatology on the examination.
In thinking about investigations, so are we doing investigations to exclude organic pathology?
Not so much to exclude it, but to see if there's additional organic pathology. So one of the big ways people go south, I think, with the FNDs is they've done tests for structural things. I've seen this a few times, and they can't find a cause. So hence, it's a diagnosis of exclusion to them. This is incorrect. FND should not be a diagnosis of exclusion. It should be a ruling in diagnosis based on positive features in the history and examination. So the tests are more to hunt, like I said, to see if there is additional structural pathology, which might help explain part of the reason the FND is there, and also help if you treat that small thing, like if someone had carpal tunnel syndrome, and you could treat that with the correct approach, which would be a splint or surgery or what have you, then I think in my experience, it makes the functional aspects of the disorder, which are usually the dominant problem to the person, it makes them easier to treat if you've taken care of the structural issue as well. So that all the tests are mainly, sometimes you get surprised. Sometimes, yeah, you get it wrong. You find something that you thought it was functional and it wasn't. That does happen. But usually the test should be to search for the presence of other minor structural things, that usually minor, that might be a part of the picture, but a smaller part.
I wonder if you can walk us through your approach to diagnosis and treatment.
Sure. Well, again, diagnosis, I'm old school. So diagnosis for me is really mostly on history, bit of examination. And then I always try to get the medical students and junior doctors to understand tests are there to confirm what your brain thinks. They're not there to give you the answer. So we fall into this trap of ordering an MRI or something to give us the answer, but that's not the way it should be. You should be trying to thinking of the answer based on your history and examination, and then you have a few differentials, and the scans are there to sort of help you out a bit and confirm things even more. So my approach is to listen and take a thorough history, and you do the same history as you would with anyone else, like whether it's a stroke or seizure or Parkinson's or something like that. You listen carefully, and you just treat it like any other disorder. You go through the whole symptomatology and signs. It takes longer with F&D, and then you go through the medical history and the medications, and you can ask about smoking, alcohol, drugs, that kind of thing, and then allergies. I always ask. So once you get through that, then you do a focused examination. You look for positive signs, as I mentioned. And at the end of that, if it's the first time I've seen the person and I'm extremely confident, and if they've already had some testing done, then we can begin the therapeutic process, which I use this 5-step approach for. If it's a first time person and I'm not, I want to look, see if there's some other structural things, and, I just want a bit more of a workup, then I may not tell them exactly what I'm thinking. I might say, "Oh, look, it might be a brain processing thing, which I don't, I won't go into too much now, but it might be something else." So then I'll order my tests and see them in 3 months, and that would be a second consult. But normally, I would try to get to, if I'm confident enough, I'll start the therapeutic approach for F&D, because the sooner you treat them, the better. They can get more entrenched if you leave them for a long time. And that's that 5-step plan, like I said, which I'm sure we'll go over at some point.
How about now? Tell us about your 5-step plan.
Okay. So, this is based on stuff in the literature. It's not like I invented it or anything, but I guess I've condensed it, and I find it very useful clinically to use this approach. So the first step of the plan is to call the diagnosis, so just name it, call it out, and say you have a brain processing disorder. They are also known as functional neurological disorders. I hate that name, by the way, functional neurological disorder. I prefer brain processing disorder because I think it's much more descriptive and accurate. But I'll say that's what you have. And I'll explain that in neurology, we get structural and functional disorders. This happens to be the latter. You can use other metaphors. So you can say, well, this is like more of a software thing than a hardware thing. Or you can say the neurons aren't communicating. There's no actual structural problem. They're just not talking correctly. There's a number of different ways you can explain it. And I guess I tailor it to the person in front of me. That's the first step. You just say, this is what you have. And you don't tell them what they don't have. And you definitely don't say, good news, it's not MS, or good news, it's not a stroke. No matter what the answer is, it's good news to you, but to the person with an F&D is it utterly disabling. And so it's not good news for them to be told what they don't have. They want to know what they do have. And so I really get into that and say, this is what you have. And I'm really confident. I think if you're, I wouldn't say this if I wasn't really confident. Second step is to try and explain a mechanism as to how it works, because people, doctors included, have a very difficult time understanding what a functional neurological or brain processing disorder really is. What exactly is that? Now, step 2 is super critical. It gives the person a way to conceptualize it. And if you can't conceptualize a thing, that's bad, especially in F&D, where, uncertainty, F&D throughout has been with us for hundreds, if not thousands of years. And throughout history, it always crops up in times of great socioeconomic hardship and uncertainty in the environment. So, and that has to do with the fact that the brain, when it sees holes in its knowledge, it tries to fill them in by just generating its own ideas about reality. And that's what F&D sort of is, I think. Patients making predictions about what their body's doing that are not entirely coherent with reality. So the second step basically is I tailor to the person again, but I try to explain a bit about how the brain works. So I explain the brain is not like a computer. The computer has sensors, it senses information, it does a central processing unit algorithm of some description, and then it spits out outputs onto a screen or on a device or something like that. So the brain doesn't really work that way. It generates its own reality. And so it goes throughout life building up this internal cognitive model of the world, and it uses that model of the world to make predictions in the real world. And if the predictions are correct, then the brain just sort of goes along. You almost perceive, see, hear, feel your own cognitive model as much or even more than the real world. It's a really weird thing to try and grasp, but there's a lot of data supporting this in the neuroscience literature. And so I explain to people that I use a few illusions, checkerboard illusions, and there's other illusions. It's kind of fun actually to show how even the normal brain can get fooled into not really seeing reality, but seeing a skewed version of it. And then I just explain, well, FND is just that taken to an extreme. The brain is creating an ultra skewed version of reality with respect to certain things. So your arm is shaking because the brain thinks there's a problem in X, or you're getting these attacks because the brain thinks there's a problem in X. That's step two. That's huge. If I get past step two, then we get to step three, which is where I focus on this thing called distraction therapy. That's the key. So FND, I liken it to something that steals the brain's attention. Attention is a very complicated process in the brain, established through the cortex and thalamus mainly, and probably some other structures. But the whole point of FND is it steals the brain's attention towards itself. So the person will ruminate on their symptoms excessively. They'll keep thinking about their symptoms, about all these different symptoms. And the more one does that, the worse the darn thing gets. So the F&D will grow as the person focuses. So the answer is to distract the person from their symptoms. And by doing that over time at a subconscious level, not a conscious one, the F&D will improve. You can't just turn it off consciously. So I ask the person to focus on things in reality. I ask them about what are their interests? What are the things they love to do, hobbies and things like that. So if it's riding a bike, and guess what? When they ride the bike, if they're able to ride the bike, they may not be able to. That's when the symptoms get their best or go away. And why? Because they're paying attention to something they love outside of themselves. So distraction therapy is about paying attention to something you love outside of yourself. Now, if someone has a movement problem, like a weakness or a difficulty walking, I can actually ask some of my physiotherapy colleagues to see these people. Some of them are schooled in distraction techniques. There's a variety of distraction techniques that a physiotherapist can use to help improve someone's walking. So rather than like a stroke or something where normally a physiotherapist would support the weak side, in distraction therapies, the physio is trying to distract the person from their weakness, and that will make the weakness better. And they're not really trying to support that weakness, because the more you support it and pay attention to it, the worse it gets, right? Whether it's the patient or people around them. So that's step three. And so I might ask a physio to help me on step three. It depends. If it's dissociative attacks, that's not appropriate. But for other ones, it might be. Step four is to treat, I usually do step four very quickly. That's to treat a coexisting mood disorder if there is one, depression or anxiety being the two common ones. But usually, I don't know, off the top of my head, maybe 2/3 people I see those are sequelae of the F&D. So the depression, anxiety I've been building up for months because nobody can figure out what the problem, the neurological disorder is, and the neurological disorder is highly distressing. Now, there is about a third of patients where that's not the case, and there's antecedent, psychological or even psychiatric issues. In those people, I actually need the help of my psychology or psychiatry colleagues, because I think most F&D does not require psychological or psychiatric-based approach, but I think maybe some do. And so that is where you get into this idea of a multidisciplinary approach, which we're sort of in the midst of trying to establish at Waikato Hospital. So that's step four. Usually I can do step four very quickly because the ones that get referred to me in neurology tend to be very neurological, and there's not a lot of psychological or psychiatric stuff in there as well. And the fifth step is to give people handouts, so to try and self-empower them. So tell them about sites they can go to. There's two I like. There's one called neurosymptoms.org, made by neurologists who specialize in F&D. It's really good. And there's another one called F&D Hope that I use, which is made by people with F&D. There's other sites, there's Facebook groups, things like that. So you give them information on where they can go to look for more, and maybe talk to people that have these. And so I actually print up the handouts on the top 3 symptoms. Remember, there's usually going to be 10 plus. So I take the 3 worst ones and I try and focus on those. If you try to focus on all 20, you're going to be there all day. And then I also mention, like, this is what you do if and when a relapse occurs. So some people will be more prone to relapses than others. And as you said at the start, like younger people, especially younger women, they can have I think if you do this correctly, you have an excellent prognosis. You absolutely do. But as people get older, men and women both, it gets harder and harder, I think, to get a satisfactory outcome, like satisfactory outcome being resolution of symptoms or great improvement in most of them. So I find, you might be able to improve things to a point, but getting full resolution in people who are older is very difficult. And in a simplistic level, that's because the brain is a bit older and things are more entrenched. Maybe the symptoms have been brewing away for a lot longer, maybe years. And so it's just harder in my experience. So that's the 5-step approach in a nutshell.
Magic. Thank you. So you did mention prognosis as far as a younger brain and a shorter duration of symptoms. Are there any other factors that influence long-term outcomes?
Well, so age, gender are two big ones. They really are. I would say how long the FND has been present is a big one. If it's been there just for a few weeks or a couple months, then that's a good prognostic factor. And I see that as it hasn't had time to establish itself much. But if it's been there for maybe a couple years or more, that's a worse prognostic outcome. If you have coexisting structural disorders, that probably would make things more difficult in terms of improvement as well. Because as long as those are there, and if they're part of the sort of overall clinical picture, then it's going to be hard for the FND, the functional overlay, to go away completely. Other things, I would say those are the. I guess if the person is resistant to the diagnosis somehow, assuming you've done it correctly, I find this very rare, by the way, that people are resistant. It does happen once in a while, but if you do this correctly and properly, and respect the brain for it, it's sort of this predictive processing, the power of it, which is what goes awry in FND. If you really respect that and understand that, able to relay that to the person, then usually you get a fantastic. People get very. The standard response is tear sort of a person will cry with tears of joy kind of thing, and then I know that's a really good prognostic indicator. If that means they get it, they understand, and finally they've been listened to, and someone's helped them conceptualize what is going on. If someone is sort of has any resistance after the 5-step approach, which again is rare, that's a bad prognostic factor. It means there's some serious internal resistance, or maybe I'm wrong. So you always got to look at your own, look at yourself and go, am I messing this up? Did I get this one wrong somehow? Because that's an atypical finding. So there are many things that I think affect prognosis, and that would be some of them, but certainly not all of them.
To conclude our podcast, Matt, some take-home messages for our listeners, please.
First one is, as GPs, you'll see a number of these, I would say, because it is so commonly referred to us. So I would say, if you think you have someone with functional neurological disorder, really see if you can open up some more time to do this properly and listen and get all the symptoms down. That would be the first thing. Second thing is on the history, try to exhaust the symptoms and ask about fatigue and insomnia, see if those are present. The third thing is maybe just do a little bit of an examination, try to do something somewhat thorough, do the proper neurological examination, like inspection, tone, power, reflexes, coordination, sensation, but also maybe do a couple other techniques looking for positive signs. And then the third thing is always just take these things seriously, treat them like you would any other disorder, expect bizarre symptoms. That's absolutely typical, and expect something very complex. And don't, if you bring your preconceived notions to the table that, there's something wrong with this person in their head, or this sounds silly, the person will sense that. These people are often very empathic. And the last thing would be, if you do this right, especially in a younger person, the outcomes can be spectacular. So it's absolutely worth trying to change our own conception of these people as difficult patients to a conception of, well, I can help this person improve from this thing quite a lot if I do it right, and especially if they're younger. So those would be my main take homes. And of course, yes, as GPs, I guess the last thing is time is an issue. So you need to refer to a neurologist or someone like that at some point. That being said, we're getting overwhelmed with this disorder as well. It's probably our number one referral at Waikato Hospital now, over and above headache. So we are starting an FND clinic. Its first one will be next month, and I'll be one of the main people running that, I guess. But it's going to be only select people, very few people that really need the help the most. We're not going to be able to have a big FND clinic anytime soon. But yeah, if you're having trouble, then refer to us, and we'll see if we can take them on.
And that's for patients living in the Waikato or throughout New Zealand?
I better say across the Waikato, because otherwise we might get more referrals than we can. We already have more referrals than we can probably handle. So yeah, I'll say across the Waikato.
Well, thank you so much for your time today, Matt. It's been really enjoyable chatting with you again. If you're a New Zealand GP and would like to claim CPD points for listening to this podcast, our podcasts are eligible, so please log them, and you'll find a list of resources that Matt has mentioned on our website, goodfellowunit.org. Thank you for listening.